So our next speaker is Philip Britton. We've already heard about Phil as a mentor for Gemma, but we're going north of the lungs, so we're going to the brain and talk about encephalitis.
Yeah, thanks very much. One feels like this is the sort of left of field presentation in this meeting, and maybe it's been put after lunch to wake you up, hopefully not confuse you. So my list of conflicts is pretty short. I did get paid by BioFire to do a consultation in 2019, but the reason was they include HHV6 in their multiplex PCR panel for CNS infection, and it was a terrible decision. So I was trying to convince them to revoke it. I don't think it's happened. And Sanofi paid some money to the Children's Hospital to the research account when I gave a talk in 2022. So this is what we're going to go through. Lots of depth at this meeting so far. This is going to be a very shallow sort of skate across the top, so there'll be plenty of things I don't address. So what is encephalitis? It's a complex neurological syndrome caused by inflammation of the brain, and Sarah Long in her textbook of paediatric infectious disease describes it as one of the most challenging conditions for clinicians to diagnose, treat and manage because of the severity of the illness, the vast number of potential etiologies, ineffective treatment options for many causes, and a lack of an identifiable etiology in most cases. When I read this quote, I think, great, it's a wide open research field and there'll be somewhere for me, right? But the other thing that I think here is prevention's very difficult when you have a severe disease that's the end point of multiple causes. Just discussing prevention, and that'll come out in the talk here. Why is it important? Well, the main one that I wanted to emphasise today is the consequences. This is a cause of death in adults and children, as well as significant neurodisability. And if we look at children, which of course the area I'm most familiar with as a paediatric ID physician, this is the sort of headline. The incidence in Australia is about 4 to 8 per 100,000 population of children. There's many causes, but it's about 6 or 7 that account for 3/4 of the disease. 1 in 2 children go to intensive care, so that's, there's a clinical attack rate for intensive care for a syndrome that's pretty high. And at least 1 in 20 won't survive their acute illness. So again, this is severe disease. And amongst those who survive, 1 in 4 will have gross, severe short-term neurodisability, and something approaching 50% will have some level of impaired function over the medium to the long term. Do you all believe me? It's important? Yes, yeah, everyone's nodding. And of course, the tragedy from a clinician's point of view is we have no specific treatment for at least half of the causes of this syndrome. Again, it's a wide open field. Now, when I use the word encephalitis, of course, I'm a clinician and an epidemiologist that does surveillance. So from my point of view, I think of it syndromically. But in terms of the pathogenesis, there's really 3 groups that are important. And this is just a simple way of trying to explain that. In the top right for you, we have what you would call infectious encephalitis. The archetype is herpes simplex virus. That's pretty easy to understand because the virus, in this case, goes to the central nervous system and directly causes the lightning bolt there, the bad disease. In contrast, there's a separate group of pathogenic pathways for clinical encephalitis, which we call infection-associated encephalopathy. And that's where the pathogen, the virus there, is actually a systemic infection that triggers inflammatory disease throughout the body, indirectly causing immune activation and disease in the brain, okay? And the archetype of that is influenza, actually. And some of the work that we've done has really unmasked this burden in Australia. Now, the third group are those is immune-mediated encephalitis. So, again, the immunologists in the room are groaning as I simply try to explain this to you. But the idea here is that you've got an infection that triggers a specific immune response, and it's that specific immune response in some sort of cross-reacting mechanism that itself causes inflammation in the brain. And in fact, I've presented these as 3 distinct groups, but in truth, these things are overlapping. So for example, we know that influenza in the great majority of cases does not directly infect the brain, but of course you as influenza people know of those published cases where you can find the virus in the brain in some cases. Equally, if you look at HSV, we know that one of the most common causes of an antibody-mediated or immune-mediated encephalitis in children is post-herpes simplex virus, anti-NMDAR, antibody-mediated encephalitis. So these things are actually 3 interacting groups, and that's important if you think about prevention. We've been studying encephalitis in Australia since 2013 in collaboration with the PEDS network, which I also lead now. And this is our data of the causes of encephalitis in children in Australia, and the top 6 there are parechovirus and enterovirus, both small RNA viruses. The severe end of bacterial meningitis, which causes then direct parenchymal damage to the brain. Flu, a novel finding from our work, herpes simplex virus, and mycoplasma pneumoniae. And those who have an allergy in the room to mycoplasma pneumoniae is a pathogen, don't worry. I'm saying nothing more about it today. But of course, when we think about prevention of encephalitis, the causal distribution varies geographically, and the classic example is the flaviviruses. Now, whenever I said flavivirus, until a couple of years ago, everyone just sort of fell asleep, but now, of course, we've got Japanese encephalitis in Australia, so it's all on. And there's all sorts of other factors. In fact, probably, apart from Japanese encephalitis in our region, rabies still remains a profound and important infectious problem in our region that is under-responded to. Now, I got encephalitis and its prevention, but of course prevention's a massive topic. I'm teaching you to suck eggs, but of course prevention occurs across a whole spectrum from primordial to tertiary prevention. And here I'm going to narrow in for the rest of the talk on vaccines. It's an immunisation meeting, so we're in the primary prevention space. But really, if we want to prevent all of those bad outcomes from encephalitis, we've got to be acting right across this spectrum. And vaccines prevent encephalitis for quite a lot of the causes here. You might not think of it in these terms, but of course we have vaccines for measles, mumps, rubella, of which encephalitis is a major outcome. For polio, yes, most polio is poliomyelitis. It's a spinal cord inflammation, but some will be brain. Rabies, as I've mentioned. For the bacterial causes of meningitis, of course, the most severe manifestations are encephalitic, so that's pneumococcus, Hib, meningococcus. For the flaviviruses, for which there's vaccines for Japanese encephalitis virus, tick-borne encephalitis virus, predominantly occurs in Europe, and dengue. For varicella zoster virus, both chickenpox and shingles, and in both manifestations of VZV disease, you can get encephalitis as a complication. And for flu and other respiratory viruses. So I'm going to go through a couple of slides of past successes, and just to remind us of what vaccines has done in this area, and then look a little bit more about future challenges. So here in this graph, this is Australian data using hospital coding data, looking at hospitalisations on your right, and then administrative death data on the left. And what you can see is in children, deaths from encephalitis in Australia between 1979 and 2003 decreased considerably. I hope you believe that. Now, embedded in the squiggles there, it's always hard to see the squiggles, is the three really significant reductions in death were from HSV, because of antivirals, which reduce death but still leave lots of people with a lot of neuromorbidity. But also post-measles encephalitis, occurs in 1 in 1,000 children who had measles, got post-measles encephalitis, and then the late sequelae of measles or subsclerosing panencephalitis, SSPE. Okay, and you can see we essentially eliminated SSPE in Australia with measles vaccine. And for those in the room who've actually looked after a child with SSPE, my goodness, this is actually probably the best thing that measles vaccines have done, is to rid us of that disease. But there's an awful lot of children still dying of SSP around the world, and the resurgence of measles that many of you are aware of at a global level is going to be with us potentially for 10 to 20 years as we see SSPE re-emerge in many places around the world. If we look at hospitalisations there, you can see reasonably stable, maybe a small reduction in some of the causes, but in particular I would get you to focus in there on bacterial meningoencephalitis down the bottom as a minor cause, but also if you look at varicella in purple, we actually saw a ecological association of reduction in varicella encephalitis in association with our varicella program. So yes, we've had success in multiple areas with vaccines in Australia. And of course, you know, you've seen these old figures, but there's polio and there's Hib, and we're grateful for the effect of those vaccines. But what about the new challenges? You know that before 2022 we saw a little bit of incursion of Japanese encephalitis virus into the Torres Strait, and of course we had some imported travel-related cases. Now JEV has a complex life cycle in the environment between birds and mosquitoes, and amplified particularly in pigs, but sometimes other mammals, and then that's how it gets to humans. And though this figure is actually describing the epidemiology of related flavivirus, Murray Valley encephalitis virus, what we know from Murray Valley is that it exists continuously in the north of Australia in those environmental reservoirs, but then where you get significant, often climactic events, you get shifting, and that's not really shown there particularly effectively well. You can see it in the very light grey. You get shifting of that disease with the migration of water birds, particularly down into the southwest and southeast, and then we see these periodic outbreaks. Now you know that since early 2022, well in fact since 2021 there's been 45 human cases of JEV. I downloaded this a couple of days ago, but there was a case announced in Victoria just yesterday of JEV in a human. And amongst those cases you can see there's also been a small number, 7 deaths. But in terms of the case fatality rate, 7 out of 45, again, it just reminds you that once you get clinical Japanese encephalitis, it's a really bad disease. And this is just a reminder that we now go back to 2021 with respect to this outbreak because of this case that was described up in the territory and shown genomically to have a virus associated with the later epidemic outbreak that started in 2022. Now JEV is typical of causes of encephalitis because the clinical attack rate is really somewhere around 1% of infections results in severe disease. Most of the disease with this virus is encephalitic, but you can get a myelitis as well. And really what I've shown here in the figure is what many in the room will be aware of, which is if you go to endemic regions, because most people get infected as children, even though 99% of them don't get sick, you really only see encephalitic disease in young children because people are seropositive and then seroprotected as they get older. But if you go into a new environment, and here in the bottom figure there is the introduction of West Nile into North America in 1999, actually what you see is the clinical attack rate from this infection in immune-naive people is much higher in older adults. And of the 45 cases in Australia up until now, 46 as of yesterday I guess, there's only been 2 cases in children. The vast majority are in adults. So how do we prevent JEV? Well, there's lots of factors: surveillance, vector avoidance, interrupt the zoonotic cycle. Many of you will be aware of the Aussie versus Mozzie campaign over the summer from the Commonwealth Department of Health. But vaccines, we have vaccines. There's been a long history of JEV vaccines that I can't describe. But on the left figure there shows you a study of a randomised trial of vaccine in Thailand in the 80s, showing a profound reduction. And in the right, you see the introduction of JEV vaccine in China in 2007 into their program, and the rapid and continuous reduction in JEV. So JEV vaccines are very effective. They have high efficacy in trials and they're very effective at a population level. So we've got great vaccines, but the challenge in Australia is getting the vaccine and then determining who's actually at risk. Because this is data produced by Dominic's lab, who did all the testing in New South Wales. In May 2022, there were 12 confirmed cases of JE, so the actual crude incidence is 0.15 per 100,000 people. So that starts to become problematic in terms of vaccinating that many people to prevent that many cases. But then if you actually look at the cases at risk, and this is work from University of Queensland, trying to determine the actual population at risk by geographically co-locating where piggeries are and where population centres are, and what you end up with is a crude incidence of 5 per 100,000. So in a sense, a much higher incidence in a targeted risk population, but we're still very unclear exactly which populations are most at risk and how to access them. There has been a vaccine response in Australia to date. In New South Wales, Victoria, Queensland and South Australia, AHPPC endorsed a vaccine plan in August of last year, but it's quite complicated, and more than that at the moment, the bigger problem is actually getting the at-risk population to want to receive the vaccine is a major challenge. So in fact, this complex stratified risk sort of approach to delivering the vaccines going out the window. Now we say anybody can come and get it because we got more vaccine than the people who are willing to rock up to their GP. So that's a big challenge. Other new challenges, here's influenza. Influenza causes a variety of neurological syndromes, all of which are severe, some of which result in death in children. But it's rare, right? It's a low incidence. So even though there's very poor outcomes, it's low incidence. We've done a couple of different studies to show that the incidence of influenza-associated encephalitis in Australian children is sort of somewhere between 2 and 6 per 100,000. But recently, just at the end of last year, we showed that if you actually look at children's deaths associated with influenza in collaboration with the APSU, half of children who die from influenza die from neurological flu in Australia. So that's quite striking. And we know that you probably can prevent severe neurological disease with influenza vaccines, because in Japan they gave universal influenza vaccine. And if you look in this time series in the bottom there, the black is influenza-associated neurological disease or encephalitis, and when they're giving high coverage vaccine in the top, in the black line, you see it goes away and they drop their national program and you see a resurgence. But our problem in Australia with the influenza vaccine, of course, is coverage, and that was what we achieved last year. Now, just in the last couple of minutes, just some minor comments on a couple of other things. Bacterial meningoencephalitis remains a perennial challenge. The most severe disease is associated with pneumococcus and group B streptococcus. There's a pipeline for group B strep vaccines, you heard. We've got vaccines for pneumococcus. But in fact, this is data from the UK. This is all invasive pneumococcal disease. This is pneumococcal meningitis, under 5s, 5 to 64s and over 65s. And what you see is, even if you look at meningitis, you see a significant reduction with the conjugate vaccines, okay? But you see now most meningitis is caused by non-vaccine serotypes. And of course, in the non-target age groups, or I guess we give pneumococcal vaccine into the older adults, we've seen a very disappointing impact of pneumococcal vaccines on pneumococcal meningitis. So there's a way to go here. And of course, we hope Group B strep vaccines will come online, but we haven't got them yet, and Group B strep causes significant morbidity. Other new challenges, well, we've got the neurotropic non-polio enteroviruses, and we've seen disease from enterovirus A71 and enterovirus D68. Bill Rawlinson mentioned these yesterday. And there are vaccines for enterovirus A71 produced in China. In fact, I think Nigel wrote an editorial when the first trial was done on the original vaccine. And they've got high efficacy in the clinical trials, but it's very unclear exactly how they might be used more broadly or in a place like Australia. But when we had an outbreak in 2013, there was 60-odd children admitted to hospital with severe neurological disease from this infection. And down the bottom in the right, this is work from Bill's lab showing that amongst respiratory enteroviruses, we do get these little outbreaks of neurotropic enterovirus D68, and that does put children into hospital, but it's poorly recognised and measured beyond these research collaborations. And COVID does cause severe neurological disease in children, but I'm not going to have time to go through what that looks like, but it looks a bit like the kind of severe neurological disease that flu causes. Now, in adults, it's very different COVID neurological disease, which is mainly stroke. Again, I don't have time to go through that. But there is a resurgent global effort to deal with this. WHO's got a roadmap to defeat meningitis by 2030. You know, there's also a global action plan on epilepsy and other neurological disorders. And there was a round table with WHO on encephalitis control just last year. So there is a great hope that we can reactivate people around something as complex as needing to deal with multiple causes to prevent one bad outcome. And a reminder to you all, which you all know, that World Encephalitis Day is the 22nd of February, so please wear red for World Encephalitis Day, and thanks very much for your time.
Fabulous. Great communicator. You've made encephalitis interesting and understandable. Are there any questions or comments? Lance.
Thanks very much for that great talk and raising awareness about this issue. You mentioned the encephalitis associated with influenza in Japan, which has always been a puzzle why they've reported it to us influenza folk. Do you have any more insight into why Japan has been more aware of this issue than the rest of the world?
No, I don't have great insight into why they've been more aware, to be honest with you, because it goes back to effectively the 50s and 60s, really. But there's quite large research groups that are very interested in this. I do think that the uptake and availability of MRI in Japan at a population level is much greater. So in a recent period, the heterogeneity of the neurological phenotypes described, which have all been described in Japan effectively, has been largely because of access to MRI, I think. But there's also been this terribly long myth that, oh, this just happens in Japan, there's got to be something weird about the East Asian genotype. And really, that myth needs to be exploded, because a large national study in the UK in 2014 or something, 15, showed that all of the syndromes are present in the UK. We've shown they're all present in Australia, and increasingly now the Italians have published on it, the Americans have published on it. So it's there in all of these places, but has been under-recognised. And I really do want to emphasise that figure of, at least in our most recent analysis in Australia, half of influenza deaths in children are neurological deaths, which is a really striking finding, which means we've got a long way to go in terms of working this out.
David?
Yeah, thanks, Phil. That was great. On Japan, remember a decade or so ago, decade or so ago, they were finding rotavirus in encephalitis cases, and that seems to have gone away, or I don't know, gone away or become unfashionable or something. But is that, it's two things. One, is that still an entity, which I haven't heard about for a while? But the second thing is this, as you said, there are all these ones which are probably infrequent, but are causes of encephalitis. And what's coming out of the big studies? I mean, what's coming out of all the metagenomics and that they're doing that give us meaningful new pathogens?
Yeah. Well, there's two things I'd really want to emphasise, which is there's always been a lot of clinical nihilism around encephalitis. Oh, there's all these causes, and you can never make a diagnosis, so it's just all too hard. Actually, we have shown, and everybody else shows, that 3/4 of cases are caused by a relatively small list. You need to diagnose them early, and we need to really move into improved management for those. It is true that there's still a significant fraction of unknown or difficult to diagnose, and the new technologies that Bill described yesterday are helpful for that, but there isn't a silver bullet with molecular science. Sorry for those virologists in the room, that where that stuff is being implemented into clinical practice, it provides an incremental diagnostic yield, but it doesn't solve all your problems yet. And we're really going to need to pull in, and Bill could discuss this, I'm sure you could discuss, David, that pulling in the multiplex agnostic serological techniques as well as the multiplex agnostic, molecular direct detection techniques. We've got to put it all together, I think. Yeah.
So, Bill.
That was great, Phil. Just 6 years ago, Wheeling Teo published her JAMA paper on using IVIG, which sort of helped in EVA 71. I guess the two questions are, do you think that should be put to some kind of a trial? Is it interesting enough? And I guess secondly, in terms of pathogenesis, do you think it's actually stopping viral replication, or it's simply an immunomodulator, in which case you might extend it to other post-viral or sort of viral-induced things like, say, influenza encephalopathy?
Yeah, thanks very much. The full answer we'll probably have to talk about afterwards, but what I think that piece of work has done is it's again emphasised that in a sensitive tissue like the brain, paradigms that say we treat the immune system or we treat the virus, we've got to throw them out. And COVID's been such a powerful news story because all the interventions that really make a big difference in COVID are directed at the immune response, not the virus. So it's reminded infectious disease physicians, respiratory physicians, and I'm hoping, if there's any neurologists in the room, to remind people that we need to actually be combining immune modulation with anti-infectives if we want to achieve the best outcomes. Because really, the child wants you to protect their brain. They don't care which mechanism's in play. The COVID patient wants you to protect their lungs. They don't care what mechanisms. But we've got to explode. These are mixed pathogenesis syndromes, and we've got to get anti-infectives and immune modulators together into clinical trials. And if anyone wants to work on a JEV clinical trial for Australia, we really are trying to put together a group of people to hopefully design some sort of comparative effectiveness trial for Australia so that we can actually randomise people moving forward rather than do what people have been doing for 50 years, which is whatever's in the hospital pharmacy.
A very quick question or comment from Peter.
I'm very over time. Jane's looking not happy with us.
Yeah, very quick question. Do you think if we start to roll out JEV vaccines, there'll be any cross-protection for Murray Valley, given the relatedness of the virus?
Dom and I were talking about this in the taxi on the way. Well, there is some cross-protection. You can show it. Just how much there is, I don't know. And of course, and David's the person to talk to about Murray Valley epidemiology, but like we get 10 infections 10 clinical every 5 years, right? So how are you going to really show this is going to be part of the challenge. You're going to have to do it in some other way than just looking at human severe disease, I think. And yeah, that's right.
Phil, thank you. Absolutely sensational.